那么接下来我就将时间交给今晚的主讲嘉宾张敏博士，那有请张博士。
谢谢大家啊。今晚我讲的 topic 是关于新冠的药物治疗。那由于我对中文方面学术的词语还不是很熟悉，我这边是主要以英文来讲这次课然后呢，如果大家后面就是有什么问题的话，可以用中文或者英文的形式来讨论都可以。这边我也把我的 email 还有我的微信的联系方法给大家了。如果大家对于新冠药物的使用，或者说有什么资料想一起进一步探讨或者怎样的，可以通过不好意思 email 写错了写成我单位的 email 写错了。我的 email 这里有我的 email 还有 WeChat 的联系方式，然后大家可以通过 email 或者 WeChat 这次就是课讲完以后如果私下想要进一步的关于药物治疗有什么疑问的话，可以进一步在 email 或者 WeChat 里联系接下来我就以英文的形式来做一些概述吧。Hi everyone, my name is Min and I'm a pharmacy clinical specialist from Boston Medical Center. I'm also a adjunct clinical professor at 2 different schools. So I actually take students for pharmacy clinical rotation in a hospital, but I also teach at a couple of pharmacotherapy class at 2 different pharmacy schools. Those are my objective for today. First, we'll describe the life cycle of SARS-CoV-2 and identify possible target for drug development. Then we will talk about some of the clinical and safety data of pharmacotherapy in outpatient and inpatient setting. Lastly, we'll talk about data to justify pharmacy-based COVID-19 test and treat program. I have no financial disclosure or conflict of interest related to this presentations. So this picture kind of illustrates the very first discovery that shaped our current understanding of SARS-CoV-2 infection throughout the intracellular viral life cycle. So step 1 is mostly the virus SARS-CoV-2 is an envelope positive sense single-strand RNA virus. And the initial binding is involving spine as protein to the cellular entry receptors, such as ACE2 receptors. Then the third step was the host-derived protease actually cleave S protein to permit infusions. After following the host entry and uncoding, the positive sense RNA genome, the reason we call it positive sense RNA genome is because that gene is translation ready genome, and then it can be translated directly to make viral protein, producing 2 polyprotein, which are further processed into the individual non-structural protein involved in viral replication and transcription complex. The viral RNA synthesis is in step 5, produce full-length copy that are incorporated into the newly produced viral particle. And number 6 is virus assembly process. Newly virus was forming here. Patients with SARS-CoV-2 infection or COVID-19 can experience a range of clinical symptoms from no symptoms to critical illness. The criteria here for each category here for the spectrum may overlap or may vary across different clinical guideline or trial. And a patient's clinical status, their symptom may change over time. So what we mean asymptomatic is you have a positive test, but no symptoms. Mild means you have kind of a common cold symptoms, like similar, like fever, cough, sore throat, headache, you feel fatigue, you do not have shortness of breath, no abnormal chest imaging in this mild illness. Moderate illness, usually there's evidence of like lower respiratory disease or infection during clinical assessment, or your chest X-ray is there's evidence of pneumonia. And also people usually have a good oxygen saturations on Romer here in moderate illness. So most patients, most people in mild to moderate illness category, you do not need to hospital care. You could stay home for supportive care, or if you're eligible to receive some of the outpatient pharmacotherapy like medication if you are at high risk for progression to severe disease. And we'll talk about what kind of things is high risk in the later. Some of the moderate illness patients may need hospital care just because you have other underlying comorbidity like diabetes, hypertension, that kind of a complicated your care. Even though you present with moderate illness, you could have a good oxygen saturation, you do not have shortness of breath, but you do need hospital care just because your underlying condition got complicated by COVID-19. And then severe illness is usually individual who had what we call desat oxygen saturation. You desat quickly, less than 94% on Romer. There's a respiratory rate, increased respiratory rate. You have shortness of breath, and there's a lung infiltrate or evidence of pneumonia. There also some degree of lung infiltrate greater than 50%. And critical illness is usually individual who have like respiratory failure, septic shock, or multiple organ dysfunctions. So patients present with severe or critical illness need to be admitted to the hospital for inpatient care. Acute disease progression, when it's related to the day, the first, there's stage one. Stage one is mainly early infection related to viral replication. Stage two is abnormal chest imaging on your chest X-ray. And stage three, what we call kind of a host hyper-reacted, hyper-inflammatory response. Your body is, your immune system is overreacting, has all the elevated inflammatory marker going on. So there can be significant overlap among the phases, and not everyone will progress to the stage 2 or 3. Most people will have stage 1, and some people will have stage 2. Not everyone will progress to stage 3. So the early phase we'll talk about is viral replications. In subset of patients, the host, your own immune response is continue to amplify, increase, even though the viral load is decreased, but your immune response is hyperreactive, hyperinflammatory condition going on, which result in hyperinflammation phase. The inflammatory marker we talk about is elevated at this stage on stage 3, and we could see like secondary organ damage here. So to identify and track SARS-CoV-2 variants, CDC has a national genomic surveillance system. They collect the specimens for sequencing through the National SARS-CoV-2 Strain Surveillance Program, as well as sequence generated by commercial or academic laboratory, contracted by CDC, state or local public health laboratory. So as of September 24th, here, Omicron BA.5 and Omicron BA.4 are the predominant strands of variants in the US. So let's move on to talk about pharmacotherapy in outpatient setting. Usually we follow two different guidelines for treating COVID-19. Is NIH, the guideline published by National Institute of Health and IDSA, Infection Diseases Society of America. So both NIH and IDSA guideline, their recommendations have been updated regularly, continuously reviewed to provide important update for doctors, pharmacists, and other healthcare provider on the management and treatment of COVID-19. NIH preferred regimen is usually Paxlovid and Remdesivir. Paxlovid giving 5 days, Remdesivir for 3 doses, giving within 7 days of symptom onset. Alternative, you could use those monoclonal antibody like betalovimab and Manu Piravir. One of them is within 7 days and the other one is within 5 days. For IDSA in particular, the guideline do not have ranking or preference order. They suggested Paxlovid, Monopiravir in patients with mild to moderate COVID-19 who are at high risk of progression to severe disease based on individual comorbidity or contraindications. Suggested Remdesivir in mild to moderate non-hospitalized patients. Those are for 3 days only. And Covalescence plasma in patients with immunosuppressive treatments. So NIH guidelines are easy to read and digest, applicable to clinical practice. They have more chart, tables, and graphs, are better organized by group of treatment type rather than listing it in a chronological order. But I do feel like IDSA's guideline has evidence-weighted recommendation, what they call grading of recommendation, assessment, and development and evaluation. So they follow that grading system to develop evidence-based recommendation. Both guidelines kind of against use of ivermectin and hydroxychloroquine. They also regularly update the evidence showing that lack of efficacy as large trial data coming for ivermectin. So basically ivermectin not recommended for use, and the same thing for hydroxychloroquine. Paxlovid, first let's review how Paxlovid is working. Paxlovid has 2 components there. One of the is a small molecule that is orally active, was specifically designed to tackle COVID-19. It's not a repurposed drug like Remdesivir, but it's actually derived from a precursor that was active against SARS-CoV-1 back in 2003. Nirmatrelvir is an active component that is actually bind to the virus main protease here called MPRO in step 3 shown here, which is a key upstream step before it get into RNA replications. And ritonavir, it's just using as a booster, is a CYP3A4 inhibitor. What ritonavir does is actually just increase the nirmatrelvir's plasma concentrations. So I'll talk about the result of a couple related clinical trial. So one of the key trial is called EPIC-HR trial, is evaluation of protease inhibition for COVID-19 in high-risk patient. This is phase 2-3 randomized double-blinded trial in non-hospitalized adult patient who has like risk factors, one risk or more risk factor for progressing to severe illness. And you compare that Paxlovid twice daily for 5 days versus placebo. The patient population is unvaccinated. They don't have vaccine during a time when the Delta variants was predominant. This trial, actually, the final analysis over 2,200 people show that there's 89% reduction in risk of COVID-19 related hospitalization or death compared to placebo in patients treated with 3 days of symptom onset, and 88% reductions in patients treated with 5 days of symptom onset. And you could see 94% reduction for age 65 or greater. So it means the higher the age, the more benefit is to prevent hospitalization or death. Secondary outcome they also have a viral load at baseline and day 5 for 500 patients that have the viral load available. So it could actually decrease the viral load by approximately tenfold. So this raises a question about, can decreasing viral load actually help to prevent transmission, especially if it's like people in a household? Say if one of the family member has COVID positive and isolated in a room, and they take Paxlovid, and they can wear the mask. Maybe they could, if they are indicated for Paxlovid, and they take the drug, and it will decrease their viral load. Maybe it will help prevent transmissions from among the family member who live in the same household, or family member, or in the school, like among public area, like working area or other things, or hospital employee, this kind of question. And then treatment emergent side effects were similar between Paxlovid and placebo group. The second trial is actually evaluation of protease inhibition for COVID-19 in standard risk patient. So this is also phase 2 randomized double-blinded study. Include unvaccinated adult who are low risk, so it's not high risk patient population. All vaccinated adults who have one or more risk factors. This is both during the trial is during the Delta and Omicron period. So far, we have interim result at 80% of enrolled patients, and it showed that 0.7% hospitalized or die in Paxlovid group versus 2.5% in placebo group. Also, it show the same result about decreased viral load by tenfold, similar to previous study about decreased viral load by tenfold, and similar adverse event here. The real world data is recently published based on Israel study. So researchers, they obtain electronic medical records for member of Clay Health Service. It's one of the healthcare organizations covering 50% of patient population in Israel. So the study period was actually in January to March this year, when the Omicron variant was the dominant strain in Israel. In this retrospective cohort study, the outcome is compared in 3,900 patients who received Paxlovid versus 105,000 patients who did not. So overall, about 80% of patient population has like previous immunity. They have vaccination, they have prior infections, or both. So I kind of put it in a box here. Among patients age 65 or older, the hospitalization were actually less likely in the Paxlovid group versus placebo group in patients who did not receive Paxlovid. And then the benefit, you can see the benefit is to carry out. So regardless, patients, if you have immunity, either through vaccinations or previous infection, or you don't have immunity, the benefit here is helping to reduce hospitalization and death. So actually, for age 65 or older, this is regardless what's the benefit, it's very clear. So we'll probably strongly recommend elderly patients to take Paxlovid after they have a COVID test positive. And then among patients aged 40 to 64 years old, there's no benefit was observed regarding the rate of hospitalization in Paxlovid treated patients compared with untreated patients. And next one, I would talk about the rebound phenomena, because rebound phenomena is a topic of great clinical interest. It's on the news all the time. But there's not much like large real world data. So Mayo Clinic researcher, they studied the outcome of 483 high-risk patients who treated with 5 days of Paxlovid. The median monoclonal antibody screening score was 3. For them, they have an institution's monoclonal antibody screening score, which is suggesting this is a high-risk population for severe disease progressions. A median age of 63 years old and 93% are fully vaccinated. And the time from positive test to getting Paxlovid is actually only 1 day. So very quick turnaround time for people who are actually high risk for progression to severe disease getting the drug. And 4 patients had clinical rebound, which they don't need retreatment or hospitalizations. 2 require hospitalization, but the author actually noted that those 2 require hospitalization. They go to hospital. It's nothing related to COVID-19. There were no deaths. The big limitation for this study is retrospective. It's not randomized controlled trial. So as a result, we're kind of suspecting the 0.8% rebound rate here maybe underestimate the true incident. And let's look at another one, which is the data on one of the trial we talk about, the EPIC high-risk patient populations. The phase 2-3 double-blind randomized control study, they have a data about the rebound, Paxlovid rebound. So when they defined the recurrence of COVID-19 was half-log increase in viral load on day 10 or day 14 if only one value was available, on day 10 and 14 if both values were available. This perspective study, they actually find out from baseline through day 14, the viral load rebound actually occurred in 2.3% in the Paxlovid group and 1.7% in those patient population who did not receive Paxlovid. So even if you don't receive Paxlovid, you still may get rebounds phenomenon, which is 1.7%, similar, very closer to Paxlovid's rates. And we know that in the real world, there's a lots of Paxlovid treatment out there. So I won't be surprised if we see the rate of 5% rebound, because it happened. It happened to patients who did not receive Paxlovid. It happened to patients who received Paxlovid. What still remain unknown is whether treatment with subsequent, like if you have a rebound, do you need another treatment? Or does that treatment actually reduce? Or paradoxically, does it increase the total amount of time that people are contagious? Or if the total time is the same, does it just delay the time that a person can say they are in the clear phase? So those are the questions remain unanswered. Hopefully there's more study. Let's talk about the second oral antiviral drug against COVID-19 is called Manu Piravir. So Manu Piravir is inhibitor of viral replications, shown in stage 4 here. And there's a clinical trial called MOVE-OUT trial. So MOVE-OUT trial is phase 3 randomized placebo-controlled double-blinded multi-site study of non-hospitalized adult patients. So not patient in the hospital, it's patient who has mild disease and they don't need hospital care with COVID test. And at least they have one risk factor. So those risk factors could be you have diabetes, hypertension, you have lung disease, you have kidney disease, you have liver disease. If you have one of those risk factors, you are the same thing for Paxlovid and Monopiravir. You are eligible to get those antiviral therapy. So the earlier you get it, the better. Why? Because remember we talked about that graph of phase 1, phase 2, phase 3. So phase 1 is actually viral replication period. So during viral replication period, if you could inhibit viral replication, why not take it earlier? The primary outcome here was to evaluate efficacy of Manu Piravir compared to placebo for percentage of people who are hospitalized or die from the time of randomization through day 29. There's 3% absolute risk reduction and 30% relative risk reduction here. And the risk of death was actually 89% lower with Monopiravir group. The incidence of side effects were compatible between Monopiravir and placebo group. And this is a oral antiviral comparison chart between Paxlovid and Monopiravir. They have similar EUA criteria. The emergency use authorization criteria is similar, like within 5 days of symptom onset, positive COVID test, and you have a high risk, we just mentioned. If you have any of the comorbidity, you're probably at higher risk for progression to severe COVID. You are eligible to get Paxlovid or Monopiravir. And the difference between those two drugs is Paxlovid is also used in pediatric patient who's greater than 12 years old and weigh at least 40 kilos. Both of them are 5-day therapy. Paxlovid, a lot of people reported Paxlovid. They have this change in their sense of taste. I heard a lot of people have their sense of taste change, but that's usually temporary. Like if you take within 5 days, probably during your therapy, and then the taste will come back to be normal again. Might have a diarrhea, drug-drug interaction. So Paxlovid might interact with a lot of a drug out there, but the most concerning one is usually the transplant drug. So people with a transplant patient, they might need to have a close monitoring when they started Paxlovid, or they might choose alternative agents or alternative medication, avoid Paxlovid. So follow up with your doctors who's actually transplant doctor, and they will give you advice how to do that. And the pharmacists can, or doctors can help with looking at the medication and screen for drug interaction. Because the interaction, when you look at the drug-drug interaction, there's drug interaction. Is it very clinical relevant, less clinical relevant? What do we do? Do we monitor it when you are taking it, both drug, or do you making dose adjustments? So it's different between drug to drug, but the most concerning one is the transplant drug or other immunosuppressive drug. So bring it up to your doctor's attention, your pharmacist, to help with the screening as well for drug-drug interaction. There's no data for Paxlovid in pregnancy or lactation. So usually is risk out of benefit versus risk discussion. I know that a couple of obstetric physicians actually have a discussion with the patient. Some of the patient with during pregnancy, they're actually taking the Paxlovid, and I did not hear any adverse outcome associated with it. So it's benefit versus risk discussion because there's no data available. And Monopiravir is actually contraindicated in pregnancy because of animal data had causing fetal harm. And the counseling for people who is childbearing potential. For females, you probably want to have reliable contraceptions 4 additional days after last dose. For male, it does require 3 additional months after last dose. And Paxlovid does not require, or does require dose adjustment depending on your kidney functions. It's not recommended in patients who's having severe kidney disease or severe liver disease. Monopiravir does not require dose adjustment in renal or liver impairment. And then we'll move on, talk about monoclonal antibody. What are monoclonal antibody? Monoclonal antibody is usually, next one is about remdesivir. So remdesivir, there's a remdesivir is one of the RNA-dependent RNA polymerase, so it interferes with viral replications. There's a randomized controlled double-blinded trial also study in non-hospitalized patients with COVID-19 who have symptom onset within 7 days, and again, at least have one of the risk factors for severe disease progression. And the most common conditions for those risk factors, like if you have diabetes or overweight, obesity, and hypertension, those are common risk factors in the trial. And the COVID-19 related hospitalization or death actually occur in 2 patients versus 15 patients in the placebo group. So this actually saying that remdesivir, the conclusion is remdesivir actually result in 80% lower risk of COVID-19 hospitalization or deaths. And the limitation of the study is this study does not include patients who have received vaccine, so they excluded patients who received a vaccine, and is conducted before the emergence of Delta variants. So it's even before Omicron variants. And the enrollment size, they actually stopped it when only less than half of the planned enrollment was achieved. So the result is based on half of the planned enrollment. It's not based on the sample size. So they do not have enough sample size, so maybe underpower. And we'll talk about monoclonal antibody, which is designed to mimic the body's natural immune response, available as treatment for COVID-19 for patients at high risk for progression for severe disease. Neutralizing antibody actually could block the viral replication by binding to the viral spike protein here. So I have a monoclonal antibody bind to the spike protein and prevent the virus from interacting with the cell here, your own cell here, through the cellular receptor. Neutralized antibody can also bind to the viral spike protein and block the conformation change. But the previous slide we showed that there's a infusion step between the virus and the host cell, so it could cause conformation change so that the spike protein cannot fuse into the host cell. And we talk about, so monoclonal antibody belong to passive immunization, similar as convalescent plasma therapies. This is a timeline of all the monoclonal antibody have been approved, have received FDA EUA. This include banalimumab, and then almost 2 years ago, casdatifan and imdevimab. This is combination of 2 monoclonal antibody, and this is also banalimumab atacicept is also a combination of monoclonal antibody. Then we have first case of Delta variants in the US. Then another monoclonal antibody called sotrovimab is approved under EUA criteria. And the first case of Omicron's variants in the US, then we have this Evusheld. Evusheld is also a combination of monoclonal antibody, 2 monoclonal antibody. And then lastly, the most recent one is batalavimab, which is EUA approved in February. So I just want to show the timeline here. So this is how timeline related to different variants. This is a table to compare those monoclonal antibody. Is very hard to keep track. So I think it's table or picture presentation will help to kind of compare and contrast the similar and difference. So initially, when those EUA come up, we have a couple, right? Previously during Delta and Omicron BA.1 subvariant period. We actually have a few monoclonal antibody here for treatment. So this is for treatment for my people who are at high risk for progression to severe disease state. And there's 2 agents actually for post-exposure prophylaxis. But remember, those are approved during Delta periods, not Omicron variants period. So it might not work for Omicron. And there's 1 agent for post-exposure prophylaxis here. Post-exposure prophylaxis means after you get COVID and you are also super high risk, you might consider getting Evusheld. And the current state, so those post-exposure prophylaxis, Evusheld was pre-exposure prophylaxis. You don't have a COVID yet, but you're high risk for having severe disease, so you could get pre-exposure prophylaxis. And those 2 combination monoclonal antibody, they were studied for Delta variants, not through the Omicron variants, so they no longer approved for post-exposure prophylaxis. And so sotrovimab was effective for Omicron BA.1 subvariants, so it's not active against BA.2 variants, so it's no longer recommended because our populated strengths in the community is BA.4 and 5 variants, and those data are not available. So what we left here is beltelovimab for treatment purpose, and Evusheld is for pre-exposure prophylaxis. What we left here for current state is only 2 of those category of monoclonal antibody. So I like timeline. So what we left is here. So bamlanivimab EUA was revoked February 2021 last year. And then this bamlanivimab atezolizumab is only used when infected with susceptible variants, and sotrovimab is no longer authorized due to increased COVID-19 caused by actually Omicron BA.4 subvariant or 2 subvariants in April. So I also do a comparison chart about this monoclonal antibody called beltelovimab as outpatient use to treat mild to moderate COVID-19 in adult and pediatric patients here. It's a recombinant monoclonal antibody to the spike protein, and is unmodified in the FC regions. And you need to use it within 7 days of symptom onset. It's 1 syringe over 30 seconds. And Evusheld is pre-exposure prophylaxis. So pre-exposure prophylaxis in adult and pediatric patients, again, at least 12 years old and at least 40 kilos. For immunocompromised, if you take an immunocompromising medication, or if you have an immunocompromising disease that your body cannot trigger sufficient immune response after getting vaccine, you could take Evusheld for extra layer of protections. And for those who has contraindication for COVID vaccine or who did not get COVID vaccine, think about taking Evusheld if you are at high risk, like super high risk in like immunocompromising individuals. And this is 1 dose is 2 separate injections, and then you could do repeated dose every 6 months. So if people who got like COVID vaccine, they can wait at least 2 weeks to getting this Evusheld. Now I have a table here to talk about different monoclonal antibodies. So the first 2 is no longer recommended. There's no information available for BA.4 or BA.5. So basically they are not working. There's no data, or they're not working for Omicron variants. And sotrovimab was working for Omicron BA.1 variants, but not for BA.2 and BA.4 and 5. And beltalavimab is still working, still recommended for the variants we have, BA4 and 5, BA2, and Evusheld is still recommended. Now let's talk about pharmacotherapy in hospital setting. Probably the first drug we talk about is remdesivir. So remdesivir is not only just used in outpatient setting, but it's also used in inpatient setting. Remdesivir has demonstrated inhibitions of SARS-CoV-2 in vitro, and there's a couple trials here evaluate the safety and efficacy of remdesivir in patients hospitalized with COVID-19 and is evidence of pneumonia. In the first trial called ACT1 trial, it was administered as 200 milligram loading dose on day 1, and then they will get a maintenance dose through day 2 through day 10, or until patient got discharged from the hospital. The primary outcome was time to clinical recovery. So this is time to clinical recovery at 10 days versus 15 days. So 10 days, faster recovery in remdesivir group. Mortality-wise is lower, and mortality-wise is lower. I think the side effect-wise is probably higher percentage. So a significant difference was actually driving by patient who require supplement oxygen, so not for mechanical ventilation patient. So this kind of tell you maybe we could use it upfront when people presented to the hospital with a symptom onset, like 5 days, within 5 days of symptom onset, but not require supplement oxygen, but not mechanical ventilation. And a simple one trial is another randomized multi-center evaluate the benefit of 5 days versus 10 days. And it shows that 10 days longer days of remdesivir does not lead to any additional clinical improvement compared to 5 days. So nowadays in the hospital, I think most institutions will use 5-day course. And simple 2 trial also showed lower disease progression with remdesivir, which consistent with ACT1 trial here, and lower incident of progression to severe disease and mortality. And then we have WHO solitary trial. It's probably the largest trial today, 5-fold large, more patient than ACT1 trial. It's an open label design. It might have a risk bias. There's no benefit of remdesivir or mortality. Most benefit is for faster symptom improvement. And there's another trial, recent one called ACT2 trial, time to recovery. It actually combined with one of the GNS inhibitor called baricitinib, 7 days versus, so faster time recovery, 7 days versus 8 days. And generally is very tolerated. So combination of remdesivir with baricitinib actually have a statistical significant reduction in time to recovery. So it helped with the symptoms, faster symptom improvement. There's no effects on other secondary outcomes such as length of hospital stay or mortality. There's no increased risk of VTE or infections complications in baricitinib because one of the concerns for baricitinib, the GNS inhibitor, it's increased risk of DVT, like blood clot. And mechanism of SARS-CoV-2 associated cytokine storm. And we'll talk about this briefly because this is like a stage 3, we talk about stage 1 of virus replication. Stage 2 is pulmonary disease, right? You have evidence of pneumonia. Then stage 3 is a hyperinflammatory state. So in severe COVID patients, excessive secretion of this IL-6. IL-6 and other pro-inflammatory cytokine is actually trigger T cell aggregation and cause T cell functional exhaustions. The cytokine storm also actually result, the hyperinflammatory state also result in the disruption of vascular endothelia, activation of messing up with your coagulation pathway. So that's why you see in COVID patient, they might have a higher risk of blood clot, right? So controlling the COVID-19 induced cytokine storm is actually very important in improving severe COVID-19 patients' prognosis. And our old drug using it for this use is, previous slide. So glucocorticosteroids has a powerful anti-inflammatory property, which has been used in several immunological and rheumatological conditions. Dexamethasone may be the preferred one. Dexamethasone may be the preferred corticosteroid using in COVID patient because it's long acting. You don't need to taper, like decrease the dose or taper, they gradually decrease the dose and taper it over the prolonged time, just because the half-life is 53 hours, so tapering is unnecessary. And then dexamethasone also have this kind of minimal cortical activity, which it does not cause resorption of water from the kidney, avoid the potential for worsening oxygenation due to pulmonary edema in COVID patient. So here we go, the dexamethasone is anti-inflammatory in fact in the lung that facilitate improvement in oxygenations. There's an open label placebo-controlled trial of over 6,000 patients with COVID-19, and they were assigned patients to receive dexamethasone 6 milligram IV PO once a day for up to 10 days. And those who actually receive dexamethasone actually have a decreased 28 mortality. So this is a drug that's showing the mortality benefit compared to those who receive placebo. So remdesivir, we see that it's helping with clinical improvement, but dexamethasone is actually helping with mortality. So this is a first-line agent using in hospitalized COVID patients, actually in patients who require oxygen. So the mortality benefit is actually, when they further examine the mortality benefit in the trial, it's actually associated with the patient. Actually, you could see that among patients with COVID-19 who actually require invasive mechanical ventilation or supplemental oxygen, means they have shortness breath, their oxygen saturation less than 94%. So those patient population is clearly a mortality benefit for using dexamethasone. There's no mortality benefit in those who did not require respiratory support, oxygen supports. So normally if they presented fine and they don't have a shortness breath, they don't need oxygen requirement, we don't give them dexamethasone because there's no benefit to use those patients. This is similar, and there's another trial study if higher dose of dexamethasone, 12 milligram, will provide additional benefit. Actually, there's similar result. So the mortality is similar, if anything is similar. So higher dose doesn't mean it's better. So it's reasonable. You could just limit it dexamethasone dosage to the minimum effective dose, which is 6 milligram, either by mouth or through the IV injections. So we talk about IL-6 inhibitor. In this, IL-6 play important roles for triggering the hyperinflammatory response. So there's 2 IL-6 inhibitor, and there's a couple trial I actually put it out here for IL-6 inhibitor. Mainly is tocilizumab, actually is the one that has those trials showing they might have better clinical status or lower mortality in patients who were receiving like in the severe COVID state. And there's another IL-6 called Sirolimus. Sirolimus actually has conflicting results. So in the Sirolimus study, they actually did not find improved early outcome in patients with moderate to severe COVID-19 pneumonia. So tocilizumab in those trials actually showing better outcome or data in terms of clinical improvements than Sirolimus. So maybe there's more study need to be done to define which subset of patient will benefit it. For now, the guideline actually suggesting using tocilizumab first, and if your institution does not have tocilizumab, you might consider using Sirolimus, but the data is more strong with tocilizumab. So I did a table comparison between pharmacological treatment for patient who's in the hospital. Dexamethasone we talk about is anti-inflammatory. You could use it up to 10 days or until hospital discharge or when you go home. Usually some of the patients we started dexamethasone and they have like their sugars, their glucose. One of the side effects is the increased risk of higher hypoglycemia, it's increased blood sugar. Some of the patients, they have sugars got messed up and we need to give them like close monitoring for sugar. So if they're ready to go home, they are on their day 6 or 7 of dexamethasone. We usually don't need to complete their therapy. We can just stop dexamethasone when they're ready to go home. We don't need to send patient home with the dexamethasone just to complete 10 days therapy and also need glucose monitoring for a couple of days. That's really unnecessary. If they are stable enough to go home from hospital, they don't need additional day of dexamethasone. Dexamethasone is only using patient require supplement oxygen. And then remdesivir is used for 5 days or until hospital discharge. So if they use it for 3 days, we use it 3 days and they get better, then there's no additional dose needed. We will avoid remdesivir in creatinine increase in severe renal impairment or hepatic impairment. Tocilizumab is 8 milligram per kilogram, the IV one-time dose. There's no repeated dose needed. Repeated dose, you may give another repeated dose if clinical improvement is not observed within 24 hours. And then doses back actually based on actual body weight. Sirolimus is alternative agent. If tocilizumab is not available, it's one time only. And then JET inhibitor is baricitinib and tocilizumab. Those you can use Janus kinase inhibitor. Those you can use it up to 14 days. Both of them you could take it by mouth, and it's kind of a renal dose adjustment as well. And it's for in-hospital use. So it's not, we don't discharge patient home with those agents. And those are common side effects. Dexamethasone is like increase your glucose level, hyperlipidemia, increase your sodium. There's water retention, fluid retention. It might increase your white counts and increase your risk of infection. And I see a few patients reported mood changes, and there's rare report of gastrointestinal hemorrhage. Remdesivir might prolong your prothrombin time, increase LFT. And remdesivir initially, when it was used in the hospital, there's a concern about remdesivir. It might cause like kidney injury because it's formulated in this SBE beta CD vehicle, but it's renally eliminated. Because it's short-term use, you use it for up to 5 days. So it's unlikely will cause renal injury. And tocilizumab, the IL-6 inhibitor, you might see reversible neutropenia, nausea, diarrhea, increased liver functions, secondary infection. Janus kinase inhibitor, there's a concern about DVT, blood clot, and there's secondary infection or increased LFT. Lastly, I want to move on and talk about some of the regulation or some of the strategy to increase availability and accessibility of those oral antiviral medication in outpatient setting. So one of the act called PrEP Act declarations, the Public Readiness and Emergency Preparedness Act authorized the Secretary of Department of Health and Human Service to issue this PrEP Act declaration. And there's several active PrEP Act declaration related to COVID. Some of those declaration and guidance have a significant impact on practice authority for pharmacists. Because I'm a clinical pharmacist in a hospital, so we kind of looking at those regulation. And then in the 9 amendments in September 2021, the 9th amendment actually authorized licensed pharmacists to order COVID-19 therapeutic. So those oral antiviral, we just talk about Paxlovid, Manu Piravir, right? Biden administration test to treat program was effected in April this year. And it's kind of it's not very clear if Biden's like treatment test and treat program is applicable to all the pharmacists, including pharmacists in the community. It's clear that it's pretty much pharmacy-based clinic, community health center, and long-term facility. If they have those testing site and they test patient and patient's COVID positive, then maybe immediately they can prescribe oral medication for those who test positive. That would be great turnaround time for people test positive. They have risk factor for progression to severe disease. And then we could give them the oral antiviral medication as quickly as possible, right? That would be ideal. That's what the test and to treat program ultimately goal is, to give people the medication when they indicate it. The initial EUA for Monopiravir and Paxlovid, they did not include pharmacists for prescribing oral antiviral medication. On average, I want to talk about some of the statistics here. Patients have access to and visiting their community pharmacy more than any other healthcare setting. On average, patient visiting pharmacy 35 times each year. And this is 7 times more than they go to their primary care provider. During the pandemic, there's a whole bunch of pharmacy emerging as a vital location for COVID-19 testing. So in some of the locations, pharmacy perform about 50% of COVID-19 tests in their community. And then pharmacy-based test and treat model have not just COVID, we have those test and treat model in pharmacy world for infection disease such as influenza and acute pharyngitis have been implemented for years and demonstrate to be safe and efficient of providing care for patients with acute infections conditions. So those model actually increase access to care and decrease time to receive appropriate antimicrobial when needed, right? Since 2015, there are 153% increase in pharmacy, just the pharmacy location that actually have those certificate. The laboratory certificate, which is the federal standard for laboratory testing certificate of favor. And the increase is like 153% increase here. So pharmacists' scope of practice, pharmacists as an essential member in medication reconciliation process in the health system, we actually help to decrease medication error. So myself, my daily practice is we do a lot of medication reconciliation. Like we have a MedRec technician who actually obtain and interview patient and getting medication history from the pharmacy. And I review those medication history. And we try to compare home medication and inpatient medication list. If there's a discrepancy, we talk to the provider. So I round it with like medical team. I provide medication consultant for physicians, nurses, and drug information questions for doctors and nurses and other healthcare provider in the hospital. So pharmacist scope of practice has continued to expand into very complex therapeutic drug management. So in the hospital, we have like over 100, some of the medical center or hospital, more than 50% of the hospitals has clinical pharmacists, like with 100 employee clinical pharmacists located in different area to provide clinical service. And in the M-Care setting, in the M-Care clinic, there's M-Care pharmacists. They also have those collaborative drug therapy management approach with doctors, physicians, and nurse practitioners in a clinic, providing chronic therapy drug management like hypertension, hyperlipidemia, anticoagulation, and asthma, COPD, all those chronic disease management. And pharmacists in some state, they can prescribe hormonal contraceptive. And there's a pharmacist run HIV PrEP and pre-exposure and post-exposure prophylaxis. They do talk to the screening patient for pre-exposure, and they also screen patient for post-exposure, and they can prescribe medication antivirals for HIV for pre-exposure and post-exposure under meeting certain criteria. So in July, there's a revised EUA in the Paxlovid language. Actually, the FDA has determined that pharmacists can actually test and treat patients who has high risk factors for progression to severe disease. But there's a couple of things like checklist the pharmacists need to do in order to prescribe, test, and treat. So the first things is make sure if you do test and treat location, you need to be CLIA certifications. This is a Clinical Laboratory Improvement Amendment of 1988 established, which are federal standards that will actually establish quantity standard for laboratory testing. So this is a checklist if you see LIA testing center. And there's a checklist for provision of follow-up care. So if check your state pharmacy practice to determine if and how pharmacists are authorized to provide follow-up care to patients subsequent to the result. So it means if they have a COVID positive, what kind of procedure they will treat. And we do have a established checklist in a few, in some of the pharmacy location to talk about. So in order to, if COVID positive and patient has a risk factor for high risk for progression, and what will be the step for pharmacists to follow in order to prescribe patient with Paxlovid, the oral antiviral medication, as soon as possible. So first of all, you need to have patients' kidney functions accessible within past 12 months. Either you have direct access to electronic medical record. So for those pharmacists that M-Care pharmacists affiliate with the clinic or hospital, we share those medical chart together. So it won't be an issue with them. For community pharmacy, they might need to call the doctor's office or the doctor's office can contact them and they can do verbal report over the phone, or just through the patient medical pool access to see if there's anything to make a check. And impacted liver function also need to be assessed within 12 months. So there's a various way the pharmacist can access the chart and look up those information. And medications. So most pharmacies have patients like full medication lists already. Or they can interview the patient or talk to the doctor. So after those three criteria are met, and they also need to screen for drug-drug interaction, and they make a clinical assessment, and they can actually, if patient is have those information available, and they can actually prescribe Paxlovid. Otherwise, follow the standard procedure is you can't prescribe that because the information is not sufficient. Then the pharmacist can refer those patients to their doctors or independently schedule an appointment, or they call the doctor for the patient and send patient to the doctor's office. Or if they're eligible for other like remdesivir or monoclonal antibody, the pharmacist can help actually refer those patients to locations that has those monoclonal antibody or remdesivir available for high-risk patient populations.